Hello, everybody. Welcome to the second episode of EMS Rapid Reviews. I'm Frank Tift. I'm an EMS and ER doctor in Chattanooga, Tennessee. And this video series is meant to be exactly what it sounds like. Rapid reviews for EMS providers that you can easily watch while on shift. I got some good feedback from the first one. A lot of people said they really liked the idea of kind of quick videos that you can watch. Didn't really get any suggestions for topics, so I'm just going to kind of do common things that I think are worth talking about, kind of basing off of common protocols that are probably in your protocol book. Also, to begin with, the posting is going to be kind of haphazard, scattered based on when I have time to do these videos. But if this really takes off and gets popular, we might become more regular, like a weekly thing or something like that. But we're going to move on quickly here and talk about anaphylaxis today. It's something I think is really worth talking about because it's an acute emergency where there's one particular thing you can do to fix the problem. So it's something that's really important for EMS providers to know about. There's also a couple of subtle presentations of anaphylaxis that I think are worth getting into and reminding you guys of and reviewing. Quick pathophysiology, it's not much to anaphylaxis. In your immune system, there's some particular cells called mast cells, and to some degree basophils as well, whose job is to release a bunch of mediators that kind of help the immune response, one of which is histamine. And histamine's job is to dilate the vessels and also make the vessels more leaky so that fluids can get out into the tissues. When we're talking about a local reaction, like an injury or a local infection, that's actually a really good thing because you bring more blood to the area, which brings along with it all the other immune cells, as well as like clotting factors and things like that might be needed for an injury response or an immune response. But if it happens throughout the whole body, which is what happens in anaphylaxis, obviously that widespread vasodilation is going to cause low blood pressure, eventually shock, eventually death, which is what we want to avoid. In anaphylaxis in particular, as the way we know it, your body has developed antibodies to something we don't normally consider to be a problem, like some sort of food or a bee sting or something like that. But when you get exposed to it, since it's more of a systemic reaction, it causes all those problems that we want to avoid. So how are we going to treat it? Actually, before treat it, I'm jumping ahead of myself. Let's talk about how we diagnose it. And this is what I really want to stress. And we're going to talk about, there's actually 3 different criteria that you can use to define anaphylaxis. Some of them are pretty obvious and exactly what you would think about, but others maybe not so much. So first off is criterion 1. You use criterion 1 when there's no known exposure at all, like they just kind of start having symptoms and but have no idea what caused them. But it can still be considered anaphylaxis if they have really kind of quickly, as in minutes, maybe hours, but usually minutes, have developed some sort of skin or mucosa involvement, so a rash or swelling of the mouth, swelling of the throat, something of that degree, plus either respiratory depression or drop in blood pressure. Again, that's skin and mucosa have to be there. Doesn't have to be both, can be either skin or mucosa, but it has to be one of those two, plus either respiratory or drop in the blood pressure. Now, the next one is the one that's potentially a little bit more subtle. Criterion 2 is when they've been exposed to something that they don't know that they're allergic to. Like say maybe a kid who's eating peanuts for the first time, or somebody who's been stung by a bee and didn't know that they were allergic to bees but has never really been stung before in their life, that kind of thing. Here you've got 4 potential systems that could be involved, and if any 2 or more of them are involved, it counts as anaphylaxis. So same sort of stuff, skin mucosa, respiratory compromise, dropping the blood pressure, or GI symptoms, which is the one that I'm not sure everybody's aware of, and I want to make sure we review and that you know it. There's a lot of histamine receptors in the GI tract, so you can get GI symptoms, and particularly vomiting with anaphylaxis. So some of these subtle reactions are going to be things like somebody with an exposure that is fairly likely to be a potential allergen. Then they get a rash and are vomiting a whole lot, but might not have any sort of throat, tongue, swelling, respiratory compromise, anything like that. It's just rash and throwing up. That can be considered anaphylaxis in the right situation. Something maybe even more subtle would be like they're throwing up a lot and their blood pressure is getting a little soft, but they don't have any rash at all. They don't have any respiratory compromise at all. Still, that can count as anaphylaxis, and it's important that they get the epi early. You can see why a lot of people would be hesitant to use epi in that situation because it's kind of non-specific symptoms. But I mean, if you've got a pretty clear exposure to something that could be an allergen and they're vomiting and their blood pressure's getting bad, it's probably worth giving them some epi. The third one is also pretty straightforward, is if they're exposed to something that you know is an allergen to them, as soon as their blood pressure starts to go down, that's considered anaphylaxis and they need treatment. Obviously, they'll probably get all the other things too, but with a known allergen, as soon as their blood pressure starts going down, they need epinephrine. So treatment is epi, and that's the main thing that you need to know. That's the main thing you need to give that's going to save people's lives. A lot of people are really hesitant to give epi because they're worried about side effects from like tachycardia or arrhythmias, those sorts of things. But in general, risk-benefit of somebody who meets one of these criterion for anaphylaxis is that they should get it because it's going to save their life. Now, it can actually be given any of the three main ways: IM, IV, or sub-Q. IV is usually reserved for persistent or recurrent symptoms, so that's probably going to be something we'll do in the hospital, but some of you might have protocols out there that let you do it in the field. But really, don't start off with IV. Kind of start off with one of the others and move to IV if needed. IM is the really common one because it's super quick and easy to do. Sub-Q is also a possibility. Actually, let's talk a little bit about the difference between those three. Okay, so the main difference here is really just pharmacokinetics. IV, IM, SQ, as far as like how much drug gets into the bloodstream and how quickly it gets there. So for IV, as you can imagine, say this is the x-axis going to be how much drug versus how long it stays around. For IV, it shoots up immediately and then kind of relatively quick downfall as well. For IM, on the other hand, it's actually still goes up pretty darn quick. Not quite as fast as IV, but it goes up really quick, and then it's going to take a longer time to come back down rather than IV. So it gets you a little bit longer time of effect with IM. But again, the real benefit of IM is how quick and easy it is to do because you don't have to start an IV or anything. Sub-Q, though, is also valid use. It's just going to be more of kind of a gradual hump that takes longer to come up, but also lasts longer and sticks around a really long time. That can be beneficial in some situations. I used it once in a child who was really a toddler at this point, and his only symptom was red skin everywhere. Like he was red from head to toe, but didn't have any other symptoms of anaphylaxis, so we didn't rush to treat him or anything. But when other treatments weren't helping, gave a little bit of sub-Q epi, and he felt fine. After like 15-20 minutes, everything was gone and he was feeling great. So that's the kind of situation where sub-Q is really helpful. But this is really the difference between the three. As for dosing, most people think of 0.3 milligrams as being the main dose. Really, the weight-based dose is 0.01 milligrams per kilogram, up to a maximum of 0.5. And so the way to think about that, particularly when you're having to deal with kids, is for every 10 kilograms that they are weight-wise, they get another 0.1 of epi. Otherwise, a lot of places just stock the EpiPens because it's quick and easy and you don't have to think about it much. Standard EpiPen has 0.3 milligrams in it, which is a big part of why people think of 0.3 as being the standard dose. An EpiPen Junior has 0.15, and you should use an EpiPen Junior on anybody that's less than 25 kilograms. Another thing about EpiPens that I want to remind you is when you stab it into their leg, you got to hold it there for a couple of seconds, like 10 seconds. Don't just stab it in and take it out, because since you're not actively pushing on a plunger, it takes a little bit for the medicine to get in there. All right, now I'm running out of time, so we're going to run through the rest of the drugs pretty quick because none of the other drugs do anything to save the patient's life. They're really just for symptoms. So antihistamines, obviously, are going to be the biggest one since this is a histamine problem. But it mostly helps with the skin effects, with like the rash and the itching. So the big one are H1 blockers, most notably Benadryl. And we'll talk about dosing on that one real quick because that's what most people use. Benadryl's dosing in an adult is anywhere from 25 to 50 milligrams, either PO or IV. In a kid, it's 1 milligram per kilogram up to a total of 50. You can also use some of the newer ones like cetirizine, which is Zyrtec, and it's a little bit, it doesn't cause as much drowsiness. They also take a little bit longer to kick in. After that, you can also use H2 blockers, which some people might have been confused about why are we giving Pepcid or Zantac to an anaphylaxis patient. It's because there's actually a lot of histamine receptors in your GI tract, but they're H2 receptors instead of H1 receptors. This is part of where you get those GI symptoms from as part of anaphylaxis, but they're also in the skin to some degree. And so giving some Pepcid or some famotidine might help a little bit with the symptoms as well. Dosing is up there if you want to pause and look at it. Finally, the other one that everybody's familiar with is glucocorticoids or steroids, the most common one being Solumedrol. The actual weight-based dosing of that is 1 to 2 mg per kg, but most people just give a fixed dose of 125 in an adult, usually IV, but it can be done IM as well. Steroids actually have not really been shown in the literature to help very much, in particular because it takes several hours for them to kick in. Kind of the main reason that we usually give them is because of the theoretical possibility of somebody being in an allergic reaction or an anaphylactic reaction, and you give all these meds to fix it that are relatively short-lived, and then they kind of have another reaction again a few hours later. But as far as the literature is concerned, it hadn't really been shown to change the rates of that happening very much, but still, it's probably not going to hurt them very much, and you can still give it. In particular to somebody who's got like COPD or asthma, or somebody whose breathing is worse because of their underlying pulmonary condition that would normally need steroids, then it's going to be very helpful. Same thing with bronchodilators, which is why I had them up there on the thing. If they've got COPD or asthma and now their breathing's bad because of an allergic reaction, then the bronchodilator is really going to help your symptoms and help them breathe better. Even if they don't have COPD or asthma, it might help a bit. So that's about it, really. As far as a non-anaphylactic allergic reaction, we mostly just give all of these things except not the epinephrine, because since they're not having widespread vasodilation and hypotension, you don't necessarily need to risk the epi, but you can give all these other meds to help with their symptoms and then have them follow up for allergy testing or other monitoring. But as far as things to remember, the key points here today are: don't forget the GI system can be involved, so GI symptoms can be anaphylactic symptoms. Epi is what they need, and don't be afraid to give it early if they're meeting the criteria for anaphylaxis. And remember that some of those criteria can be pretty subtle, but if they meet the criteria, they need that epinephrine. And that's about it. So thanks for watching. Hope you enjoyed it. And as always, please feel free to send me some comments about things that you want me to cover. Until next time.